Thank you. So, Asha, that was really nice. I learned a couple of very good points, and so basically, I think there is a way how you look at non-unions. That's the thing. So, first of all, I must introduce myself without being very rude. I'm Hemant Sharma. I work in Hull, and my principal interest is limb reconstruction and bone infections, along with um, research in limb reconstruction. Now, so uh, in this talk, the idea would be to have basically a clinical assessment. So how do we have a logical approach when we see a patient? What do we do? I'm not going to talk to you about any of the basics and things which you all know about. So all I'm going to do is just discuss some broad management principles, but discuss some clinical assessment and how to deal with your day-to-day problems. Now, how I see as a problem is, if you have a problem, we need to identify what is the cause of the problem. And if you take the cause of the problem out or you eradicate it, then the chances are that you will get the result what you want. Sometimes you have to do something extra, but generally that's usually is good. So when you look at the bone healing, there are a couple of things you need. One is the biology, which means you need all the vascularity and scaffolding and all what it goes with it. And along with that, the other thing what you need is the stability. And as Arshad has quite uh, elegantly showed, that stability is very important. And I think the combination and the happy marriage of it leads to bone healing. Now, we don't understand bone healing, so we all try to do things differently as we think what is we have learned from our experience. But generally, these are the usual combination of things which we do. And along with this, we have a number of things, growth factors, and there's a number of cells which will work and help us. Some we understand, some we don't understand, but generally they all are present. We use some of them in a practice as well, but you need to have normal growth cells for us to achieve that. So as I said, I won't go into classification, but I will mention a couple of things. One is what we used to call hypertrophic, and as Elizarov described, is stable, and atrophic, what Elizarov described in mobile, when there's a very little callus. And when you assess a non-union, I want you to start from very basic and the things. Now, you can go to the Parent's theory and look at the strain value. But ultimately, if you look at the larger picture, there are two things you need to assess. One is the biological capacity, that do you think this non-union can unite? And two, is there any stability, or there is an instability, or there is a too much stability? Along with that, something which help you to decide to help you plan your treatment is the deformity, boneless, etc. The other thing you need to look at it is, apart from the local factors, how is your patient? And on top of that, the one thing you need to assess is there any infection or not? Now, sometimes it's very obvious and sometimes it is not. And each time, especially the trainees, I will really suggest to you that each time you see a non-union, look at these things and then move forward. And when you look at any non-union, when you assess them, you can divide things, all the problems, into two broad groups: the factors which you can control, any factors which you cannot control. And of all the things you see, the things in the red are the only things which you can control. And the rest, everything else, you have very little control. The other thing which you have control over is how do you approach surgically, if you approach it, or if you treat it conservatively, whichever way. But do not make the biology and the stability worse, so that you actually make things worse rather than improve the situation. Now, other thing I will ask you to go away with is this definition of non-union. So is a time frame, is 6 months, is 9 months, when there's no callus for 3 months, all those things. These are only guidelines. And duration of non-union has no influence on your decision and should not have any influence on your decision whether you should intervene or not. This is just very arbitrary. We do not understand it, and we use it to make a judgment which should be based on other factors rather than the time frame. So then the question comes in, when do you intervene? And there is no right answers here. So the question is, if you look at it, you start looking at it when the edges become round. If you see that there are rounding of the edges, do you think the metal might fail? Is it a pseudoarthrosis? This is probably one non-union where you think, I have to intervene. Then are there any symptoms? And sometimes you want to go in early when patient can't earn and can't feed his family, or is an elite sportsman where he has to go back to what he does. So these are the situations which you will consider all in it and decide whether you want to intervene or not. So some are local factors, some are patient factors, which will help you decide. But there is no black and white here. Other thing is the patient expectations. So there is a very fit 76-year-old gentleman who has multiple surgeries in the past. He has a short leg with a bit of a pain. He is walking around, but not happy. So his expectation from the treatment is not that his leg becomes equal, his bone heals, but he wants to run a marathon. So I explained to him, I'm really sorry, I can't help you. You must carry on. I cannot operate. I can help you in your pain, maybe the bone healing, but I cannot help you in run the marathon. And he went home and decided that probably marathon is not the best thing, came back. And then you look at it. When you look at it, you assess it. So what is the positive on our side? He's medically fit, no metabolic conditions, he doesn't smoke, he's a very involved person, no obvious infection. What is against us? His age. He has 3 surgeries in the past, and which means the vascularity is not the best. He's in varus, so mechanics is not on your side. Now, can you improve mechanics? Now, Arshad doesn't like blade plate, and I have to say I quite like blade plate in these situations because I don't use frames in the femur. So this is the plan. I put it into valgus and I correct the mechanics, and I hope it will heal. But the problem is he has the screw, a broken screw, which I have no desire to go in and take out. So I have to compromise on mechanics on a little bit. So I compromise on the mechanics a bit, put in a blade plate, but in addition, I also bone grafted him. So in a lot of these times, I will not bone graft because I don't think bone graft actually is as helpful as everybody thinks and makes out of it. But in this situation, I thought there's a bit of medial gap, I'll better bone graft it. And I grafted it. And in about 6 to 9 months' time, he healed up. Now, if he wants to run, he can. Fine. He's still a bit short. So this is other thing we need to look at it. That sometimes we have to do a compromise and look at it what patient wants. And that can we deliver what patient wants? Otherwise, we'll have an unhappy patient. So what interventions do we have? So the commonest intervention is the dynamization of the nail. Or you can have revision of the nail, or you can change the nail and put it in an external fixation. You can do bone grafting, and we'll talk about it a bit in a minute. And some extra treatment like ultrasound and bone marrow and what Arshad pointed out, PRP. So there are a lot of other things available as well. Now, nail dynamization is probably the most misunderstood concept, because the idea is it's not healing. You take the screws out and you dynamize. That's completely wrong. What we must look at it is, when you dynamize it, are you increasing the stability, increasing or decreasing the stability or instability? One thing you must do is avoid instability. If you think dynamization increases the instability, then that is a wrong procedure. You should not do that. What we need to assess is what is the cause of non-union. And if dynamization is adding to the cause, then it will never heal. What you need to do is you need to reverse the cause. And if dynamization helps to change the cause of the non-union or sort of eradicate it, like causing more stability, then yes, please dynamize the nail. So I'll come back to the same patient. This patient had a polio, 10 months down the line, pain-free, very limited walking. Now, when you look at it, if you look at it, there is a gap. So if you dynamize this, then it will collapse, it will provide stability, then perhaps enhance the chance of healing. So in this case, I have no problems in dynamizing the nail. But if it increases the instability, then I will not dynamize the nail. As compared to this hypertrophic non-union, where if you say the principal cause is instability, there is a one distal screw, is a large forces going across. If you take that screw out, it will cause massive torsional instability. It will actually make it worse. Therefore, dynamization is not a good idea in this. Here, what you have to do is you either have to revise the nail and make it more stable, or you add a plate on top of the where the non-union is, and that will help it heal, because that will provide the stability. If you have the previous nails like huckstup nail or something like that, then put couple of screws here and couple of screws here. That will increase the stiffness of the construct, and that will help you heal the bone. And that is the minimalistic approach. And I'll give you this example. This is a closed fracture. These are the post-op X-rays. Everything is fine, nothing to worry about. There is a bit of a gap here, which is a worrying, possibly yes. But what happens 6 months down the line, there you are. It's not doing anything. Now, you can take the nail out, put in a frame. You can do renailing. You can do all sorts of things. But the surgeon decided, I will dynamize it. Now, before dynamization, we should look at it, what is the situation? So on the positive side, everything is on your side. He's fit young man. On your other side, if you dynamize it, will you cause the instability? Probably yes. The biology is in some doubt because there's no callus in 6 months and there's a bit of a gap. So how are you going to deal with all these things with the dynamization? Now, dynamization will possibly leave the gap, deal with the gap, but not so, because it is only, gap is only on one cortex. It will increase this and it will possibly help in this, but not really. It will cause instability and therefore will not heal. Then this is exactly what happened. It was dynamized. 14 months down the line, if you see, it is trying to heal, it collapsed and helped a little bit. So there's a bit of callus formation, but there's the instability still there. So now your option is you can put in a plate here and that will help it heal. You can re-nail it, or you can change the nail to a fixator. I'm not a great fan what Arshad does, that Arshad was probably put in fixator on top of that and compress it and it will heal. And no doubt about it. My worry is the internal and external fixation, the infection rate is very high, certainly in my hands, and what the literature suggests. So therefore, I don't do that. But clearly, Arshad knows much better than me how to do this, and therefore he'll put the frame and do that. And that's probably another option. So then the question comes in, why do we do bone grafts? So what does bone graft actually do? It does quite a lot of things. It is inductive, conductive, and it provides the cells. And we can argue whether it is cancellous or corticocancellous, and you have different views with different surgeons. But ultimately, what does it do? That's the question we need to answer, and what is the evidence for that? So Chris Moran from Nottingham, he took a large series of non-unions, and every single non-union, he did a jute decortication and did a compression plating on the tension side. In half of the group, he did bone grafting, and other half he did no bone grafting. And the healing rate was roughly the similar. Now, this is a was a retrospective study, so you can't take just as a gospel, but a lot of us believe, and that includes me, that bone grafts are not as useful as we think they are. Mechanics are equally or perhaps more important. The other concept is atrophic non-union. And if you look at the studies, atrophic non-union is not a avascular non-union as it is as we believe. So the blood vessels, they reach the same level in the fracture, but they come at the later time point, and therefore there is an avascular and atrophic non-union. That does not mean that every atrophic non-union should be bone grafted, but that does not also mean that every atrophic non-union should be other way. We need to each case unbalance and decide whether it needs bone grafting or not. So when do I have only one absolute indication for bone grafting, and that is a gap non-union. Everything else is a relative indication for me. And there are a number of things you can think and talk about, and they all are relative indications in my practice. If I have to do, I use RIA, because I think particularly in the elderly, I don't do a corticocancellous unless it's a gap non-union, and I generally tend to use only cancellous bone grafts. Then let's go back to when to intervene. When do we actually have to do the surgery? So this is a very difficult question. You cannot answer it straightforward. So there is a high energy subtrochanteric fracture in a polytrauma patient. You can argue it's a bit of varus, there's a gap, all kind of things. 9 months down the line, it's not healing. So let's do a assessment. Sorry, before the assessment, you look at it, that it's a slight varus, there's a rounding of the edges, and there is a toggling of the nail. But we also had a bit of healing here. If you look at this nail is moving a little bit here. There's a radiolucent lines here. So, but there's very little pain. So what we do then is, we do the same thing again. We find out and there's a lot of things on our side. What is against us is possibly there's a bit of instability. Mechanics is not exactly on our side. And there is some pain. It's not massive pain, but there is some pain which may suggest that we need to intervene early in this patient. If we treat it conservatively, the risk of metal failure, increased morbidity, patient will not be able to go back to work. If we do an intervention, how do we correct the varus? Do we break the partly what is healed, and do we bone graft? Those are the things we need to answer. So what you do is you talk to patient, and then after a discussion, patient decided pain isn't as bad. I'm happy to wait. My nail might break, but we'll see. And in that case, 8 months down the line, he healed just by wait and watch. You could have equally operated if patient wanted, and you think is so. Sometimes what I'm trying to tell you is there is no right answer. We all think we know the answer, and we work around, we do all kind of things, but we do not always have the right answer. So every patient needs to be treated individually, treated in the particular and personal circumstances. Not one treatment and one thing is good for every patient. Every patient have different needs. Then I have this patient who I see every 2 years. He comes in, it hasn't united. We know it hasn't united. He has no pain. He walks around. He doesn't want an operation, and I don't want to do an operation. He's a non-union. Let's carry on. If the nail breaks, he knows I will operate. And if there's a problem with the pain, I will operate. Otherwise, I'll see him every 2 years. Now, the stability is very important concept. And as Arshad pointed out in his lovely study, particularly the shear, which is so under identified. And from my talk, if I tell you something, one thing is, if you counter the stability problem, then most of your non-unions will heal without bone grafting. And So there are a number of ways to deal with this stability. So there is a closed fracture, nailed, didn't heal. There's a bit of a gap, no infection. My friends decided to plate it, still didn't heal. And this time I did what Harshad does very regularly. So I put in a frame. But what I did is I tried my best that my internal device means half pins and my plate, um, internal or external device, uh, do not touch. So I get huge time and under X-ray. So these my half pin is between the screws and my other half pins are away. And because I'm so worried about infection, perhaps unduly, but I do worry. And it healed up. And again, without opening the non-union, took the frame off as soon as I could, and it just healed up. So then the X-ray I showed earlier. Now, normally, I'm not a great fan of femoral frames. I never do. A number of years I've stopped doing femoral frames because I found them that patients are very, very uncomfortable. So I always nail and plate. But this one, I think, needs a frame because you do that, you put in a frame, you don't open the non-union site, gradually distract. Now, Arshad showed you an X-ray where he compressed. I'm a great believer of distraction. I always distract. So I distracted, corrected the deformity, the mechanical access, which Arshad rightly pointed out, is the very important thing. Stability is fine, mechanics is fine, and it healed up without opening anything. So stability is very important. Then you look at the supportive treatment. Ultrasound, I'm not a great believer. I don't think it works. It helps heal the patients and surgeons' minds, I believe. And there is a recent systematic review. We looked at all meta-analysis and the systematic reviews, and they found that it works better in hypertrophic non-union, which basically means probably if you didn't do anything, it still would have healed. And it is perhaps some use in high-risk patients. You can buy time. I use it to buy time rather than actually heal the bone. Then comes bone marrow or stem cells. There is insufficient evidence that it is. There are a lot of studies in non-unions. We have no RCT. The French group Honorary has done some very good work. We did a systematic review on fractures, and we found that it doesn't help, or there is no high quality evidence in any way. Then other thing we need to look at is the infection. Infection may not be obvious. If it's not obvious, you have a recurrent non-union, then I suggest you follow the infection principles. Because treat it as infection, because a significant number of them are subclinical infections which may lead to non-union. So if you follow the principles of an infected non-union, then you won't have problems. Now, in past, I used to do a lot of segmental excisions. I do very, very little segmental excisions. I do local treatment, and that works very well in my practice. And this is the change of practice. 15 years ago, when I started as a consultant, I used to do almost everything was a segmental excision. And then I realized that in my practice that I don't need to do as many, and therefore my practice has changed. Now I look at it as if it's infection, whether it is an active infection or not, and a hypertrophic non-union, if it is a stable non-union or is a mobile non-union. This is how I look at it. If it is infected, if it's a quiescent and there is no active infection and it is hypertrophic, all I do is no intervention at non-union site. I do a simple distraction and it heals. This is an example of a pilon fracture. Young man, I thought I fixed his naive with the screws and frame, had an infected non-union, deep infection. I took the screws out, everything, and he ended up with like this. Infection settled. I put in a frame, again distracted it, and healed up. No non-union intervention in non-union site and nothing else. If it's an active infection and there's a bone loss, this is the one indication I do a bifocal treatment. So as Arshad pointed out, there are two ways you can deal with it. There is a gap after excision. You can do an acute shortening. You can do a corticotomy and you can lengthen it. Or you can do a transport. I tend to do uh, um, acute shortening on lengthening because how I was trained, I always, if I do a transport, I go back and um, open the docking site and graft it. This is just the practice and habit. And here, all you have to do is transport, and there are various ways of dealing with the docking site. Arsha showed one way. This is one new technique. I don't use that. I just use open up and just compress it, sometimes graft it. This is what I did here. I did acute shortening and lengthening. He healed up. That is a function, and is back to his job as an assistant physio. If you do, now, if he has infection, I would suggest do not use internal fixation. But if you do, always do a two-stage procedure. So stage 1 is clearing out, stage 2 is fixation. So this is a multiple non-unions, so multiple knee replacements. I fused the knee. She fractured at the top, so I had to extend the frame above, and she wasn't doing very well. Ultimately, when it healed up, she broke at the pin, went into non-union. So I said, I'm not doing any more things because she had so many treatments. Every time there was a complication. I put on a traction, conservative, she refused to heal. And I had no choice, but I didn't want to put in a frame because I thought if I put in pins here, she got infected, then it's a disaster because everything went wrong in this patient. So what I did a stage 1, debrided, put some local antibiotics, stabilized her locally. I didn't want to put any fixator. Normally I would put in a fixator, but not in this case. I put her on bed rest and traction and then stabilized her. Not the best, but I had a very little choice. In stage 2, I went in, put in a plate and fixed it, and she healed up. So if you're doing an internal fixation, always do a 2-stage. And normally stabilize it after clearing the infection, and then go back and do a serious internal fixation. So to summarize, infected non-union, avoid, as I said, if you can. If you have to do it, put in a 2-stage. When you put in a plate, make sure your fixator is well away from you putting in a plate, so there is no contact between the internal and external fixation. If it is a quiescent and hypertrophic, closed distraction, and that will heal, I would suggest no internal fixation. If it's a quiescent and active or atrophic non-union, then you might have to do a segmental excision and perhaps a transport or acute shortening. If it is an active infection and hypertrophic, then you have to individualize the treatment, look at it, what is best for that patient. There are multiple options you have, and you must deliver what works best for that patient. So to summarize, I would suggest that analysis of non-union is more important, assessing non-union personality and patient personality, rather than doing what you need to do in terms of without having any fixed ideas, depending on what is non-union like, what is patient like, and what patient needs and expectations are, then decide the treatment. So there's no fixed treatment for every non-union. You must individualize it. Conservative and wait and watch is always an option and works in a lot of patients. Mechanics is the most often ignored, and therefore I always suggest look at the mechanics. This is probably the very and perhaps the most important thing in that. Thank you so much.